Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interest. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A chat. Also, a link to the event survey will be shared at the end of the program, and if you're attending virtually, we will share that in the chat section. It is my pleasure to introduce our guest speaker today, Dr. Yashna Lamsal. Originally from Charlotte, North Carolina, Dr. Lamsal completed her undergraduate studies at the University of North Carolina at Chapel Hill. She earned her medical degree from Lincoln Memorial University DeBuss College of Osteopathic Medicine. Following residency, she will begin practicing as a primary care physician. Dr. Lamsal is passionate about preventative care and is committed to empowering patients to take an active role in their health. Her clinical interests include chronic disease management, obesity medicine, and lifestyle medicine. Please join me in welcoming Dr. Lamsal.
Thank you for that introduction. My name is Yashna. My talk today is why internists should ask about sleep, cardiometabolic connections. I do not have any financial interests or disclosures. So my learning objectives today are to review normal sleep physiology, explain how sleep disturbances contribute to cardiometabolic disease, recognize common sleep disorders and their clinical impact on cardiometabolic outcomes, apply screening and management strategies for sleep disorders, and then finally to discuss emerging research and technologies including GLP-1 based therapies and AI applications. So first, what is sleep? Well, it is more than just closing your eyes and counting sheep. Sleep is a natural state of unconsciousness where the body stays active, the brain rests, and responses are mostly to internal stimuli. And why am I talking about sleep today? Because we spend nearly a third of our lives asleep, and despite its importance, we're facing a widespread epidemic of sleep deficiency and sleep disorders across all stages. The International Classification of Sleep Disorders describes 83 distinct disorders, including sleep apnea, insomnia, and restless leg syndrome. Today, we're mainly going to just talk about sleep apnea. From an epidemiologic point of view, approximately 5 to 6% of US adults have a diagnosed sleep disorder. In terms of prevalence rates, for sleep apnea, it is 17 to 34%, insomnia between 10 to 20, and then short sleep duration about 37.1%. Normal sleep duration is defined by the American Academy of Sleep Medicine as 7.5 hours of sleep per night. Mild sleep deprivation is in the low 7s, moderate anywhere in the 6s, and severe is less than 6. So this graph is from the CDC. The light blue is 1985 and the dark blue is 2004. From 1985 to 2004, the percentage of men and women who reported an average of less than 6 hours of sleep per night across per 24-hour period increased across all age groups. And unfortunately, the trends have not improved since 2004. So this is from the CDC survey called the Behavioral Risk Factor Surveillance System, which is the nation's premier system of health-related telephone surveys. The percentage of adults not getting enough sleep stayed the same from 2013 to 2022. The CDC actually predicts that a third of US adults get less than 7 hours of sleep per night. And what about the healthcare burden of all of this? A 2021 Journal of Clinical Sleep Medicine analysis from Mass General found that people with sleep disorders like sleep apnea or insomnia had nearly twice as many medical visits and prescriptions than those without. They were also more likely to visit the ED and have multiple comorbidities. Overall, sleep disorders drive about $95 billion in annual healthcare costs. And as you can see in this graph, sleep deprivation costs economies billions of dollars each year, with the US alone losing an estimated $411 billion annually, which is more than other major countries like Japan, Germany, the UK, and Canada. So now going through the sleep stages, sleep cycles through 4 main stages. You have N1, N2, N3, and REM sleep, and this repeats 4 to 6 times per night. Early in the night, deep, slow wave sleep is what dominates, and later it's going to be REM sleep that becomes more prominent. N1 is light sleep, where it's easy to wake up. N2 is deeper stage of sleep, marked by sleep spindles and K complexes. N3 is deep restorative sleep with slow delta waves predominating, and there's minimal movement. And then with REM sleep, this is your dreaming stage, where the brain is highly active, you get vivid dreams, muscles are atonic, and you have irregular heart rate and breathing. Each cycle lasts about 90 to 120 minutes, with again more REM sleep in the later half of the night. So now moving on to circadian rhythm. Light is the primary signal that sets our circadian rhythm, helping us sync our internal stimuli with the natural 24-hour cycle of sunrise and sunset. Light enters the eye and reaches melanopsin-containing retinal cells, which don't aid vision, but they do detect light intensity, specifically blue light. And these signals, they travel via the retino-hypothalamic tract to the suprachiasmatic nucleus in the hypothalamus, which is the body's master clock. The suprachiasmatic nucleus coordinates hormonal rhythms across the body, influencing melatonin, cortisol, growth hormones, and also reproductive hormones. So the circadian drive is what drives us to stay awake, but there's actually a 2-process model of sleep regulation, showing how sleep timing and duration are governed by the interaction between homeostatic sleep drive and circadian arousal drive. So the homeostatic drive is the blue line that you see, and that builds the longer that we're awake, and it declines during sleep, which reflects our growing need for rest. The circadian rhythm, which is the green line, promotes alertness during the day and wanes at night. These two interact at the sleep gate, which is the point where the rising sleep pressure meets the falling circadian alertness, which creates the optimal window for sleep onset. And unfortunately, again, modern life has disrupted our natural rhythms. So we get too much light at night from our screens and too little daylight exposure during the daytime. Artificial lighting has enabled 24-hour activity, which blurs the boundaries between day and night. The result of that is circadian dysregulation, which impairs metabolism and increases the risk for endocrine, metabolic, and cardiovascular disease. So looking more closely at the functions of sleep, sleep fulfills basic biologic needs in the brain, including mood regulation, immune function, hormone regulation, clearing toxins from the brain, as well as learning and memory. We're going to go through most of these one by one. So let's start by taking a look at the brain without a night of sleep. This PET scan shows a brain that was awake for 24 hours. You can see reduced activity in several key regions. So first, the prefrontal cortex, which governs decision-making and self-control. So without good sleep, you're going to get poor judgment, risk-taking, and emotional instability. The inferior parietal cortex supports attention and sensory integration. So without sleep, you can get lapses in focus and slower reaction times. And then the occipital cortex handles visual processing. So decreased activation there would slow visual response and more errors during visually demanding tasks like driving, for example. And then the thalamus maintains alertness and relays sensory input. So disrupted signaling there would further impair attention and cognition. So all in all, sleep loss weakens the brain's ability to think clearly, to stay focused, and regulate emotion. So moving on to sleep's role in immunity, this study looked at how sleep affects vaccine response. So 19 healthy adults who had never been infected with hepatitis A received a vaccine at 9 in the morning. That night, half of the participants slept normally, and the other half stayed awake all night until 9 p.m. the next day. And after 4 weeks, those who slept produced twice the antibody levels compared to the sleep-deprived group. Sleep also shifted hormone balance in an immune supportive way, increasing growth hormone, prolactin, and dopamine, while lowering stress hormones like norepinephrine and epinephrine. So even a single night of lost sleep did blunt the immune response in this study. Now moving over to hormone regulation. This next study examined how short-term sleep deprivation affects carbohydrate metabolism and endocrine function in healthy adults. 11 young, healthy men lived in a controlled laboratory setting with a standardized diet, activity, and light exposure. Each underwent 3 phases. So you had baseline sleep, where they were sleeping a normal amount, averaging around 7 hours and 15 minutes. Restricted sleep, where they were restricted to an average of 3 hours and 45 minutes in bed for 6 nights, which mimicked several nights of partial deprivation. And then recovery sleep, where they slept an average of 9 hours for six nights. During each phase, participants had IV glucose tolerance tests to assess glucose clearance and insulin response, along with measurements of cortisol and thyroid hormones. This within subjects design allowed for direct comparison of how sleep loss alters glucose metabolism and hormonal regulation in otherwise healthy adults. So for major findings here, in terms of impaired glucose metabolism, during sleep debt, glucose clearance was approximately 40% slower, so 1.45% versus 2.4% per minute. Insulin secretion in response to the glucose was also approximately 30% lower. These changes mimicked those seen in older adults with impaired fasting glucose tolerance, suggesting that sleep deprivation may accelerate metabolic aging. In terms of hormonal and endocrine effects, after nights of sleep restriction, so remember that they did 6 nights, thyrotropic activity declined, showing early disturbance of the pituitary thyroid axis. And then evening cortisol levels were elevated, reflecting a stressed-like endocrine system. So even short-term sleep restriction, despite a controlled diet and activity in a laboratory setting, it still caused impairments in glucose metabolism and disrupted endocrine balance, which shows this how sleep impacts metabolic health. So moving on to the sleep's role in clearing toxins from the brain, this next study called Alzheimer's, Wakefulness, and Amyloid Kinetics Study, or the AWAKE study, explored whether 1 night of total sleep deprivation disrupts the normal overnight decline in CSF amyloid beta 42, which is a protein whose impaired clearance is thought to contribute to cerebral amyloid deposition. Sleep deprivation is thought to reduce interstitial fluid volume to levels that are insufficient to actually clear amyloid beta. So it was a randomized controlled trial involving just 26 healthy men aged 40 to 60, all without any sleep disorders, none taking any medications. Participants were randomly assigned to either a normal sleep group or a sleep-deprived group who stayed awake for 24 hours straight. They were continuously monitored with full polysomnography from 3 p.m. to 10 a.m. And to measure changes in amyloid levels, they actually placed an intrathecal catheter in the lumbar region to collect CSF samples throughout the night, and samples were collected at 5, 8, 9, 10 p.m., and also 8, 9, 10 a.m. to track overnight amyloid beta 42 fluctuations. So in addition to amyloid beta 42, they did measure several other CSF markers, including amyloid beta 40, which is the most abundant amyloid peptide, but it's less prone to aggregation and plaque formation. That actually did not change, indicating that the effect of sleep loss was specific to the amyloid beta 42. And total tau, which is a marker of neuronal injury, that remained stable, suggesting that 1 night of sleep loss didn't cause acute neuronal damage. And then phosphorylated tau, which is more specific to Alzheimer's pathology, also showed no change, meaning that short-term sleep deprivation affects amyloid clearance, but not necessarily tau-related pathology. And then total protein was measured as a control, and that stayed unchanged. So looking at the primary outcome, amyloid beta 42, in the group allowed to sleep normally, CSF amyloid beta 42 levels fell by about 6% overnight. In those that stayed awake all night, amyloid beta 42 did not drop. Instead, the levels actually stayed the same or actually even trended slightly upward. The contrast between the groups was statistically significant, and so sleep was required for the expected overnight decline in amyloid beta 42. This suggests that one night of sleep loss is enough to block normal amyloid clearance, keeping amyloid beta 42 circulating in the brain or CSF longer. Given that a higher level of amyloid burden is a hallmark of Alzheimer's disease, this points to chronic sleep loss as possibly accelerating that risk. The limitations of this study is that the sample size was small, just 26 participants, and the population was restricted. They were all healthy middle-aged men, and this is similar to the studies that I just talked about as well, with the small sample size and mostly being men. The study was done in a controlled lab setting, which may not reflect real-world sleep loss from shift work or insomnia, and it tested only one night of total deprivation, whereas most sleep disruption in our day-to-day lives is chronic and partial. And finally, findings were based on CSF biomarkers without brain imaging, so direct amyloid changes in the brain were not confirmed. Further studies can look at how on-call duty and sleep fragmentation in general alters the risk for, affects the risk for Alzheimer's. So far, the studies that we have discussed have been focused on sleep duration, but timing consistency, so when you wake up and when you sleep, may be as important as how long you sleep. So this, according to an article in the journal Circulation Research, sleep irregularity is defined as the day-to-day variability in when someone goes to sleep and wakes up, and in how long they sleep. In research settings, this is often quantified using the standard deviation of sleep onset, so when a person falls asleep, sleep offset when they wake up, and then sleep midpoint, which is the halfway between the onset and offset, and then nightly total sleep time or sleep duration. So emerging evidence shows irregular sleep, this day-to-day variability, independently predicts hypertension. The next few slides will go into this particular study that examined the link between sleep irregularity and hypertension. It is from the AHA Hypertension Journal in 2023, titled Sleep Irregularity is Associated with Hypertension. So this study tested whether inconsistent sleep timing itself, independent of how much someone sleeps, was associated with higher blood pressure. It was a cross-sectional observational study that analyzed objective long-term sleep data from over 12,000 adults, age 18 to 85 across 19 countries. Mostly they were in the US and Europe. Participants used a validated under-mattress non-wearable sleep monitoring device that's pictured there, called the Withings Sleep Analyzer. The sensor detects subtle body movements, heart rate, respiratory rate, and breathing pauses, and from these signals, it estimates sleep onset, offset, and duration. Validation studies show it closely matches polysomnography, though it does tend to overestimate total sleep time by about 30 minutes, which is typical for non-wearable devices. Each participant had about 9 months of nightly data, adding up to more than 2 million nights of sleep recordings. And to be included, they needed at least 28 nights of recordings, average use for 4 or more times per week, and 5 separate blood pressure measurements. And here, hypertension was defined as a blood pressure greater than or equal to 140/90. The main variable of interest was sleep irregularity, which is again that night-to-night variability in sleep duration, onset, midpoint, and wake time. And they did adjust for factors like age, sex, BMI, and average sleep duration. So first, we're going to go into how average sleep duration relates to hypertension as per findings in this study. The authors found a U-shaped relationship, which we're going to see come up again multiple times in this presentation. But this U-shaped relationship meant that both short and long sleep durations were linked with higher odds of hypertension, while the mid-range sleep duration showed the lowest prevalence. So the sweet spot was around 7.5 to 8 hours per night, where hypertension risk was the lowest. Looking at the figure, you can see that quartile 3, which is highlighted there in green, represents that mid-range group and served as the reference. Comparing that to Q1, which was the short sleepers, those sleeping less than 6.9 hours, they had a 32% higher odds of hypertension. Q2, which is those sleeping roughly between roughly 6.9 and 7.3 hours, they also had elevated odds, about 24% higher. And on the other end, Q4, the longest sleepers, sleeping more than 7.8 hours, had a 23% higher risk. So it seems like both too little and too much sleep were associated with higher hypertension risk, reinforcing the concept that moderate, consistent sleep appears to be more favorable for cardiovascular health. Now looking into how sleep duration irregularity, meaning how much someone's sleep time varies from night to night, relates to hypertension. In this analysis, it is important to note that the odds ratio don't compare quartiles of sleep to each other, but instead they're comparing individuals within each quartile. So they're comparing the 75th percentile, which are the more irregular sleepers, to the 25th percentile, the more regular sleepers. So across all quartiles, Q1 through Q4, greater night-to-night variability in sleep duration was consistently associated with higher odds of hypertension, even after adjusting for average sleep duration. So the effect is strongest in Q3, which was our reference group, the ones that slept 7.5 to 8 hours per night. And those with greater variability had about 17% higher odds of hypertension. So even amongst normal sleepers, irregular sleep pattern appears to raise blood pressure risk. So it's not just about how long you sleep, but how consistent that sleep is that matters. So that brings us to the strengths, limitations, and clinical implications of the study. Starting with strengths, it was a large global real-world data set that captured long-term objective sleep measurements. Each participant had around 9 months of nightly recordings, giving us a pretty robust picture of sleep patterns. And then they also used this validated, non-invasive under-mattress device, which reduced any bias that could come from self-reporting. In terms of limitations, the sample was predominantly male, about 88%, and blood pressure measurements weren't standardized in timing. We also don't know the impact of underlying comorbidities or shift work schedules, which could influence both sleep and blood pressure. In terms of key takeaways, the study showed that sleep irregularity is a risk marker for poor cardiovascular health. The proposed mechanism, I think, is based on sympathetic overactivity. So normally with restorative sleep, there is this nighttime dip in sympathetic tone and blood pressure, about a 10%, that is about 10% lower than daytime levels. But when that sleep is irregular or insufficient, that nocturnal dipping that happens is blunted, and that leads to persistent sympathetic overactivation, higher levels of catecholamine and cortisol, and sustained elevations in heart rate and blood pressure. We know that people who don't experience this normal nighttime dip are at higher risk for cardiac events. Clinically, this highlights that incorporating sleep regularity into hypertension and metabolic risk assessment may represent a modifiable lifestyle factor that we can target in our clinics. So we should be asking our patients not only how many hours of sleep do you get per night, but also do you wake up and sleep at consistent times every day. Some unanswered questions for future studies would include, does improving sleep regularity actually lower blood pressure? Are certain groups like shift workers more vulnerable? And how do the day-to-day fluctuations in sleep relate to next-day blood pressure or other cardiovascular outcomes? So our first question for the audience, which of the following best describes the relationship between sleep duration and hypertension risk? A, hypertension risk decreases linearly as sleep duration increases. B, only short sleep, less than 6 hours, is associated with increased hypertension risk. C, both short and long sleep durations are associated with higher hypertension risk, the U-shaped relationship. Or D, sleep duration has no significant impact on blood pressure regulation.
Okay, I have to phone a friend. What do we think? Pardon? C is in cat.
That is correct. Yep. So the relationship does follow that U-shaped curve with both insufficient and excessive sleep being linked to higher risk for hypertension. So that was hypertension. What about cardiovascular disease risk, and including heart disease and stroke? So this is another study from the Journal of American Heart Association published in 2022 that examined the link between sleep duration, napping, and sleep patterns with risk for cardiovascular disease, including heart disease and stroke. So it was an observational cohort study that used a twin design. Their objective was twofold. So one was to use a multidimensional sleep assessment, not just how long people sleep, but also daytime napping, insomnia symptoms, snoring, daytime sleepiness, to evaluate how these different aspects of sleep relate to cardiovascular health. And second, it was to assess whether genetic factors could explain what's going on here, these associations. So essentially, this study helped answer the question, is poor sleep truly an independent risk factor for cardiovascular disease, or is it just a marker of underlying genetic predispositions? The data was from the Swedish Twin Registry, which is one of the world's largest that enrolled twins born in 1958 or earlier as part of the screening across the lifespan twin study that occurred between 1998 and 2002. After excluding for those with missing sleep data or existing cardiovascular disease, about 12,200 participants were followed through 2016 for new cases of heart disease or stroke. So the sleep assessment came from the Karolinska Sleep Questionnaire, which measured nighttime duration, so less than 7, 7 to 9, which was the reference group, 9 to 10, or more than or equal to 10 hours, and then daytime napping, so no napping, 1 to 30 minutes or over 30 minutes, and then total daily sleep, so that included nighttime sleep as well as napping. In a subsample of approximately 5,000 participants, a composite sleep index combined duration, insomnia, snoring, and daytime sleepiness to classify healthy sleep, which was 4 to 5 points, intermediate 2 to 3, and then poor 0 to 1. And the outcomes were tracked via Sweden's national health and death registries using standardized ICD codes. So moving on to the results, this figure shows the association between various sleep characteristics and cardiovascular disease risk that's expressed as hazard ratios with 95% confidence intervals. Starting with sleep duration, the reference group, again, was those that slept 7 to 9 hours per night, which represents the optimal range for cardiovascular health. And compared to that, individuals that slept less than 7 hours had a 14% higher risk of developing cardiovascular disease, and those sleeping 9 to 10 hours showed no significant difference. So as you can see, the confidence interval there crosses 1. And then those sleeping 10 hours or more had a 10% higher risk. Moving on to daytime napping, participants who did not nap were used as reference here. And then those who napped for 1 to 30 minutes had an 11% higher risk. Those napping for more than 30 minutes had a 23% higher risk. And then looking at overall sleep pattern, which was again integrating all those factors, the sleep duration, insomnia, snoring, daytime sleepiness, individuals with a poor sleep pattern had a 22% higher cardiovascular risk compared to those with healthy sleep. The intermediate group did not show a statistically significant difference. So overall, the figure demonstrates that both insufficient and excessive sleep, longer daytime naps, and poor overall sleep quality are all associated with increased cardiovascular disease risk. In the within pairs analysis, researchers compared twins to their own co-twin, effectively controlling for any shared genetics and early life environment. The associations between sleep characteristics and cardiovascular disease risk remained largely unchanged, which actually suggests that these links can't just be explained by genetics. The results were similar in both identical and fraternal twins, and overall these findings support that sleep behaviors themselves likely have a direct and independent effect on cardiovascular health. To wrap up the study, there are a few clinical takeaways. First, these findings highlight that, again, sleep is a modifiable risk factor that may play a meaningful role in cardiovascular disease prevention. So counseling aimed at promoting healthier, more consistent sleep patterns could help reduce long-term cardiovascular disease risk. And then maintaining an optimal sleep duration, roughly 7 to 9 hours per night, seems to be the sweet spot. Both short and long durations are linked to higher risk. And then daytime napping, particularly when it's over 30 minutes, may be a marker or contributor to increased cardiovascular risk. So it's important for us to consider napping behaviors as part of our comprehensive sleep assessment And then finally, the study reinforces that sleep health is multidirectional. It's not just about the hours, the total hours that they get, but also about when they sleep, when they wake up, do they experience insomnia, snoring, daytime sleepiness. So it's important for us to kind of assess sleep as a whole rather than just like reducing it to a single number. So moving on to sleep and arrhythmias, sleep disordered breathing encompasses several conditions that involve disrupted breathing during sleep. The most common is this obstructive sleep apnea. You also have central sleep apnea and kind strokes breathing. Obstructive sleep apnea is defined by the apnea-hypopnea index of more than or equal to 5 events per night with typical symptoms, and then also more than or equal to 15 regardless of symptoms. Central sleep apnea differs in that it involves loss or reduction of ventilatory effort due to instability in the brainstem's respiratory control. It's diagnosed when more than half of the apneic episodes or hypoapnea episodes are central in origin. Kind strokes breathing is a subtype of the central sleep apnea, which is seen in heart failure and is characterized by the cyclic crescendo-decrescendo breathing pattern driven by heightened ventilatory sensitivity to carbon dioxide. So how does sleep disordered breathing contribute to cardiac arrhythmias? When you have repeated drops in oxygen and rises in carbon dioxide, this triggers strong autonomic nervous system fluctuations. Apneic events cause parasympathetic bradycardia, followed by sympathetic surges on arousal, producing this electrical remodeling that promotes AFib. Also, when someone is trying to breathe against an obstructive airway, you get this significant negative intrathoracic pressure, which leads to increased venous return, atrial wall stress, and LV dysfunction, which all works to destabilize the cardiac rhythm. And then at the same time, you get inflammation and oxidative stress that increases and that further destabilizes the electrical system. And this process starts after just some nights of sleep issues, and this continues over days to weeks. And over months to years, chronic exposure leads to structural remodeling. The left ventricle becomes more hypertrophied and dilated, and the atria stretches and develops fibrosis. So altogether, these repeated physiologic hits, they progressively change both the structural as well as the electrical properties of the heart, making arrhythmias more likely. So clinically, this highlights that treating sleep disordered breathing is integral to arrhythmia prevention and management. Studies show that 20% to over 50% of AFib patients have some degree of sleep disordered breathing, but it's often underdiagnosed since not all patients snore or actually report daytime sleepiness. Observational data suggests that treating sleep apnea, especially with a CPAP, can reduce AFib reoccurrence and burden, particularly after cardioversion or ablation, but randomized trials are small and inconsistent in regards to this, so a direct causal benefit on rhythm control has not yet been proven. Current AHA guidelines give a Class 2B recommendation to screen for OSA in all patients with AFib, so this does acknowledge its high prevalence, even as the effect of treatment continues to be studied. Our next question is, in the Swedish twin study, what was the key finding regarding sleep and cardiovascular outcomes? A, the association between poor sleep and cardiovascular disease was entirely explained by genetics. B, sleep duration and quality predicted cardiovascular disease risk independent of genetic or early life factors. C, only short sleep duration, less than 6 hours, increased CVD risk, or sleep patterns had no significant effect once BMI was controlled.
B as in boy.
That's correct. All right. So moving on to metabolic health, what about that? So let's talk about sleep and its effect on obesity. So body weight is controlled by a highly integrated network involving signals from the gut, adipose tissue, the pancreas, and the central nervous system. To understand how sleep interacts with obesity, it's important to kind of review some key hormonal players. So ghrelin is produced mainly in the stomach. It stimulates appetite and increases before meals. When we are sleep deprived, ghrelin levels rise, which can make us feel hungrier even if our energy needs have not changed. Leptin, on the other hand, is secreted by adipose tissue and normally acts to suppress appetite. Leptin levels are proportional to body fat, so it's higher in people with obesity, but over time there's this thing that happens called leptin resistance, which means that the brain no longer responds appropriately to the satiety signal. And then adiponectin is another adipokine with almost the opposite effect. It enhances insulin sensitivity and has anti-inflammatory properties. So obesity is associated with lower levels of adiponectin and higher leptin levels, which contributes to a more overall pro-inflammatory state. Peptide YY is a gut-derived hormone that promotes satiety. So interestingly, insufficient sleep has been shown to lower peptide YY levels, which may blunt fullness signals and lead to increased food intake. So altogether, those hormonal changes, higher ghrelin, lower leptin sensitivity, reduced adiponectin, and decreased PYY, they create a metabolic environment that drives hunger, reduces satiety, and promotes weight gain. And we're going to see how that relates in the setting of inadequate or irregular sleep. So the Wisconsin Sleep Study was a population-based longitudinal study that examined how sleep duration and quality relate to metabolic and hormonal health. It included 1,024 adults who underwent overnight polysomnography and had morning fasting blood draws measuring leptin, ghrelin, adiponectin, insulin, glucose. The researchers used multivariable regression models adjusting for potential co-founders like age, sex, BMI, and sleep apnea to explore how sleep duration was linked to both hormone levels and BMI. The main hypothesis was that leptin and ghrelin, which are the two opposing appetite regulating hormones, mediate the relationship between short sleep duration and higher BMI. So in this graph, again, this U-shaped relationship comes back. So this graph is showing the average nightly sleep and adjusted BMI. The lowest BMI was observed in participants sleeping around 7.7 hours per night, while both shorter and longer sleep durations were associated with higher BMI. The rise on the short sleep side aligns with what we know, so less sleep disrupts hunger and satiety hormones promoting weight gain. The increase at longer sleep durations, I think, is more complex. It likely reflects other underlying factors like chronic illness, depression, low physical activity, poor sleep quality that leads to longer sleep, but are themselves kind of associated with higher BMI. So in these cases, long sleep may be more of a marker of underlying metabolic or health problems. So the researchers also found a significant association between sleep duration and the hormones leptin and ghrelin, independent of BMI, age, sex, and sleep disordered breathing. So on the left, you can see that shorter sleep duration was linked to lower leptin levels with a statistically significant slope. Model estimates suggest about a 15% reduction in leptin when comparing those that slept 5 hours to those that slept 8. On the right, shorter sleep duration was associated with higher ghrelin levels. So with a roughly, again, 15% increase in ghrelin when comparing individuals who slept 5 versus 8. So the relationships are persisting again after adjusting for BMI. So this means that the hormonal changes are not just a byproduct of excess body fat. So taken together, the pattern of lower leptin and higher ghrelin with shorter sleep supports a biologically plausible mechanism. So sleep restriction shifts appetite hormones in a way that increases hunger and food intake, which may explain why short sleep is consistently linked to obesity risk, independent of weight itself. And then next, the Sleep Heart Health Study, which included over 2,000 participants, found a strong relationship between sleep duration and both diabetes and impaired glucose tolerance, which, as we know, is a precursor to diabetes. Compared with adults who slept 7 to 8 hours per night, those sleeping 6 hours had about a 1.7-fold higher risk for diabetes, while those sleeping 5 hours or less had a 2.5-fold greater risk. Both short sleep groups were also more likely to exhibit impaired glucose tolerance, indicating early metabolic dysfunction. Interestingly, those sleeping 9 hours or more showed similar risk elevations, suggesting that both insufficient and excess sleep may signal underlying metabolic disturbances. So now shifting gears to sleep apnea. To review, sleep apnea contributes to cardiovascular disease, metabolic dysfunction, and daytime sleepiness. It is linked to type 2 diabetes, fatty liver disease, and also mood disorders. Globally, it is estimated to affect 1 billion adults, so it's a major public health issue. The strongest risk factor for it is obesity, given that fat deposition around the upper airway promotes collapse during sleep. So if you look at the two diagrams on the slide, the top image, A, shows normal sleep architecture with regular transitions between wake, REM, and deeper non-REM stages, which we reviewed at the beginning of the presentation. The bottom image shows sleep in someone with sleep apnea. So there's these repeated awakenings and frequent transitions from lighter stages of sleep. So each time the airway collapses, the person wakes up briefly to reopen it, which leads to dozens or even hundreds of arousals per night. And as a result, people with sleep apnea, they spend less time in the restorative stages of sleep, stages 3 and 4, and more time in the lighter stages, stages 1 and 2. And many of the physiologic benefits of sleep that we talked about, like blood pressure dipping, hormone regulation, memory consolidation, occur during those deeper stages. So when deep sleep is repeatedly interrupted, it sets the stage for broad metabolic and cardiovascular consequences. So what is the impact of untreated sleep apnea on glucose control in patients with type 2 diabetes? Sleep apnea is really common in this population. Some studies estimate that up to 86% of obese patients with type 2 diabetes have some degree of sleep apnea. In this University of Chicago study, 60 adults with type 2 diabetes, they underwent overnight polysomnography. 77% of those were found to have sleep apnea despite not being previously diagnosed. And what's striking is this clear kind of dose-dependent relationship between sleep apnea severity and glycemic control. After adjusting for BMI, age, medication use, higher OSA severity correlated with higher A1C levels. So mild OSA was associated with an A1C increase of about 1.5%, moderate approximately 1.9% increase, and then severe sleep OSA 3.7 increase. So the takeaway here is that the more severe the sleep apnea, the worse the glycemic control, even when accounting for the other factors like BMI, age, medication use. So this really emphasizes the importance of screening for and managing sleep apnea as part of diabetes care, which we normally don't think about. These two figures together show how sleep apnea and metabolic dysfunction are tightly interconnected in this bidirectional cycle. So sleep apnea contributes to and is actually also worsened by obesity and type 2 diabetes, creating this self-perpetuating loop. So sleep apnea leads to intermittent hypoxia and sleep fragmentation and sympathetic overactivation, which triggers systemic inflammation, oxidative stress, and hormonal dysregulation, including increased ghrelin, reduced adiponectin, and also elevated cortisol. These changes impair insulin sensitivity, disrupt beta cell function, and ultimately worsen glucose control. And at the same time, obesity and diabetes feed back into sleep apnea by promoting upper airway narrowing and further metabolic dysfunction. So the key takeaway here is that sleep apnea, obesity, and diabetes, they reinforce one another through shared mechanisms of inflammation, hormonal imbalance, and oxidative stress, which drives this vicious cycle. So given all of that, the question then arises that does using the CPAP device actually improve glucose or glycemic control in patients with type 2 diabetes? The results from what I found have been mixed on this. Some studies show modest improvement in insulin sensitivity and A1C, while others find minimal to no change in metabolic outcomes. The key factor there kind of seems to be CPAP adherence. There is a clear dose-dependent relationship. Those that are using CPAP for at least 4 hours per night showed improvements, but those using less than 4 saw no effect. The diabetes sleep treatment trial, in that only participants that used CPAP for 7 or more hours per night showed meaningful reductions in A1C. So even though sleep apnea does contribute to insulin resistance and higher risk for diabetes, treating it does not automatically normalize glucose metabolism. This may be due to the poor CPAP adherence, but also because obesity, diet, and physical inactivity play major roles in insulin resistance. So just to review some key takeaways so far. So first, we should think of sleep and cardiometabolic health as this multi-hit model. It's not just about how long you sleep, but also your sleep quality and sleep regularity. Those 3 dimensions together, the duration, quality, and regularity, determine overall cardiometabolic risk. And then inadequate or disrupted sleep, whether from short sleep duration or from sleep disorders like sleep apnea, impair insulin sensitivity and disrupt appetite hormones. And then specifically, it raises ghrelin, it lowers leptin, and it drives hunger, overeating, and weight gain. And then finally, chronic sympathetic overactivity, which we see in both poor sleep and sleep apnea, lead to persistent elevations in blood pressure and cardiovascular strain over time, which can then lead to arrhythmias. So now we're going to move on to a clinical approach that we can use in our clinics. The American Heart Association in 2022 officially added sleep duration to its framework of life's essential 8s, which are the 8 key metrics for cardiovascular health. This underscores that getting 7 to 9 hours of consistent, regular, restorative sleep each night is not just beneficial, but is actually essential for cardiometabolic health. So again, it's important to consider it as this multidimensional construct. So as internists, we are in a important position to identify and address sleep-related contributors to metabolic disease. The first step is going to start with actually recognizing sleep as a fundamental pillar of cardiometabolic health. And then second, we should make it routine to include sleep assessments in our patient evaluations, especially when discussing chronic conditions, which we do all the time in the primary care clinic, like diabetes, hypertension, obesity. For more structured evaluation, we can use validated screening tools like the Stop-Bang or Berlin questionnaire for OSA risk, and brief sleep quality scales as well, like the insomnia severity index. And then sleep care doesn't actually have to just stay within one specialty. We can integrate sleep specialists, behavioral health educators, obesity medicine specialists into diabetes or hypertension management. And that can all improve and reduce overall risk and improve patient outcomes. And then finally, we can consider tirzepatide for our patients. So there are many validated sleep questionnaires that are used in clinical and research settings. This is from the Sleep History and Physical Screening Form that you can find on the American Academy of Sleep Medicine website. There are some questions that we can use to assess sleep habits. So at what time do you usually fall asleep and wake up on weekdays and weekends? How many total hours of sleep do you get? How many times a week do you nap? And then also, how long are those naps? And how long does it take you to fall asleep? And the other thing we need to do is also pay attention to the social determinants of sleep. So do they hold multiple jobs? Do they do shift work? Those are also important questions to ask. And then this is something we're all very familiar with. These are just simple behavioral strategies, and they are the core principles of sleep hygiene. So this is, consistent sleep and wake times, limiting screen exposures, keeping the room dark and cool, avoiding caffeine or alcohol late into the day, and then reserving the bed for the purpose of sleep. So sleep apnea, again, we talked all about that, but the gold standard for diagnosis remains polysomnography. But polysomnography is often expensive, time-consuming, and not widely available, especially in resource-limited settings. Because of this, we do have several screening questionnaires, and among them, studies have suggested that the Berlin and the Stop Bang are the most sensitive and accurate, while the Epworth Sleepiness Scale is useful for just kind of assessing daytime sleepiness rather than screening for sleep apnea itself. This slide is just kind of showing the difference between in-lab polysomnography and home sleep apnea testing. Both do measure core parameters like airflow, respiratory effort, and blood oxygenation, but in-lab studies are far more comprehensive. They're including all these other things like the EEG, EOG, etc. But in contrast, home tests are focusing mainly on just breathing parameters, which makes them more practical and cost-effective, but less kind of detailed for diagnosing other sleep disorders. And then in the lab sleep study, apnea severity is expressed as the apnea-hypoapnea index, which is the total number of apnea and hypoapnea events divided by the total sleep time. Home sleep study uses the respiratory event index, which is the number of events divided by the total recording time, since they can actually get a precise total sleep time outside of the lab setting. And because recording time typically includes periods when the person is awake, REI values are often lower than AHI, meaning that home tests can underestimate apnea severity. So it may underestimate it by approximately 15%. So like we talked about, the home sleep apnea testing is a practical alternative since it's more comfortable, it does use fewer sensors, and it does help reduce wait times for diagnoses, but it can underestimate sleep apnea severity. According to that algorithm from the American Academy of Sleep Medicine, polysomnography rather than home sleep apnea testing is recommended for those with significant cardiorespiratory disease, also with those with potential respiratory muscle weakness due to any kind of neuromuscular condition, awake hypoventilation, chronic opioid use, history of stroke, or if they have severe insomnia. So not everyone in our clinic is actually appropriate to get the home sleep apnea testing, and it's important to consider whether or not they have these other diagnoses. So finally, let's talk about the GLP-1 tirzepatide or Zepbound that has been approved for moderate to severe sleep apnea in adults with obesity based on results from the 2024 SURMOUNT OSA trials. So these were two large randomized double-blind placebo-controlled studies that included 469 adults without type 2 diabetes, and they followed them for 52 weeks. Trial 1 enrolled participants not using positive airway pressure therapy, and then Trial 2 enrolled those that were already on positive airway pressure therapy and continuing it during the study. So they received once weekly tirzepatide, 10 milligrams or 15 milligrams, or a placebo, alongside standardized lifestyle counseling. The primary endpoint was the change in the apnea-hypoapnea index, or AHI, and they were looking at that at week 52. So across both trials, participants that were treated with Zepbound showed a statistically significant and clinically meaningful reduction in AHI compared to placebo, so regardless of whether they were using the positive airway pressure therapy. Notable changes of cardiovascular risk factors included reductions in body weight in both trials. They also saw improvements in systolic blood pressure by about 9 points systolic, and significant reductions in high sensitivity CRP, which is a known marker of inflammation and cardiovascular risk. And in addition to promoting weight loss, they may improve sleep apnea through their anti-inflammatory effects, which we talked about earlier with that self-perpetuating kind of loop. So key strengths of the study was the randomized double-blind double-blind design, year-long duration, and also the endpoints that they were looking at. As far as the limitations, the study did exclude people without diabetes as well as obesity, and it was limited to just 1 year. So it's unclear whether Zepbound can actually replace positive airway pressure therapy, or is it best to use it alongside that? And for future studies around this drug, I was reading that researchers are also now investigating the potential for GLP-1s to affect REM sleep, which is, again, the phase of sleep associated with memory consolidation and emotional regulation. And then finally, AI. So AI is rapidly transforming sleep research and clinical care as a whole, and it's allowing us to kind of get entire nights of information with a lot of accuracy. An example of that is PFT Sleep, which was developed at Mount Sinai. It is a transformer-based deep learning model, kind of similar to how ChatGPT is interpreting full paragraphs instead of single words. This model is reading a full night of signals, so EEG, heart rate, breathing, to detect transitions between sleep stages and recognize apnea patterns in context. And then Sleep AI is automating the polysomnography scoring, reducing technician workload by about 70%. And then consumer wearables like the Oura Ring, Fitbit Sense, Apple Watch, they also use AI to estimate sleep stages, variability, and disturbances in real-world settings. And then there are also digital sleep coaches out there like the Sleepio, which integrates machine learning with behavioral therapy. So it uses cognitive behavioral therapy, and it personalizes that to improve insomnia and sleep hygiene. So all of this kind of marks that shift in medicine towards personalized, data-driven care. So these take-home points we really went throughout the presentation, so I won't go through that again. And that's all. Thank you for listening, and special thank you to Dr. Gross for reviewing my presentation.
Thank you. Do we, if you're viewing online and have a question, please enter it in the Q&A section. Also, if you're viewing online, we did enter the evaluation link into the chat section. So if you'll fill that out, that'd be great. In the room, do we have any questions or comments? Yes.
Thank you, Yashna. That was very informative. My question was the studies that were done for sleep duration and hypertension and diabetes and other outcomes that were assessed. Was the sleep time, for example, did the patient sleep at 9 p.m. and wake up at 4 p.m.? Was that standardized across the same? For example, people sleeping for 7 to 9 hours or 9 to 10 hours, was that the same for all the participants in that range, the sleep
Yes.
time and wake-up time?
It was, yes.
And was there any benefit in terms of, did you see that this time they recommended that the optimal time to sleep is at 10 p.m. or wake up at like 6 a.m. or what did they say?
I did not see any mention of that in the studies. They didn't actually say, about the time to wake up and sleep, which is a good question, since a part of what they were trying to do was kind of look at the sleep irregularity, but they did not specify which pattern is, or which time to go to sleep and wake up is best. No.
And as far as nap time is concerned, daytime nap, was there any specific time that people should nap during the day, or or there is benefit in napping during the day?
So all that I saw, it did not specify if there's like any about the timing of the naps. It was just in general the duration of napping. So if it's 1 to 30 or over 30, no specific mention of when.
And there was benefit with that, or?
So all that was shown was just 1 to 30 minutes is not as bad as sleeping or napping more than 30. That was all that was mentioned, yeah.
Okay, cool. Yeah, that's also, I think that as far as the sleep goes, there's other factors in terms of stress, anxiety,
exactly.
depression,
All
all
those
those
confounding
factors that
variables.
go into people who are not very regular with sleeping, and that probably plays a part in all of those stress hormones as well.
Absolutely.
But thank you so much.
Yeah, thank you.
Thank you, Yashna. That was wonderful. Excellent job with a highly relevant topic for not only our patients but ourselves, and a high-quality literature review. You could tell you presented very well, articulately, and you could tell the passion and the interest,
Thank you.
the effort that you put into it. So yeah, this reiterates a lot of what I had thought and believed and practiced, but now I have outcomes-based data to support that. And two questions popped to mind, which weren't answered by your studies, but I'm just wondering what you think, like extrapolated from what you learned. So there was initially a study showing like sleep-deprived versus restorative sleep, and how there's a difference in like metabolic factors. So would you say that there's a benefit to working off your sleep debt? Like if you're getting nights of sleep deprivement, would you recommend trying to work that off by sleeping longer, or maybe taking naps during the day?
So I do think that instead of naps, because the other study showed that naps may not be the best for cardiometabolic health, I do think that trying to work that sleep off, from what I learned, would be beneficial, yes.
Yeah, that's what I would think
Yeah.
too. And then my other question regarding quality of sleep, because there's a lot of people that do wake up intermittently throughout the night to use the restroom, and none of these studies kind of address that.
Right.
Maybe assuming that those people will go back into their sleep cycle, and overall it won't be affected. And the more important measures are duration, and then a consistent time that you're falling asleep and waking up, and then the absence of these like OSA symptoms.
Yeah.
But did you find anything regarding like getting up during the night and adverse effects on outcomes?
I didn't, Dr. Gross, no. I didn't find anything in my research regarding those specific things.
All right, thank you.
Important, yeah, thank you.
Thank you so much, Dr. Lamsal. I just have a quick fun question, I guess. When we're on nights, we switch,
Yeah.
right? So is it just important for us to get the optimal sleep duration, or is there any changes when we have that switch?
Yeah, that's a great question. I did not find specific studies looking at, people who do shift work, or, what we were doing on nights. But it does seem, from what I was reading, that consistency matters. So it probably is best for us to keep the same sleep schedule that we're doing when we're doing a month of nights or any kind of shift work, yeah.
Okay. We are at time. Thank you, Dr. Lamsal.
Thank
Great
you.
presentation.